Medicine continues to increase in complexity, making it impossible for one person to manage hospitalized patients on their own. It takes a team. When health professionals effectively work together, efficiency improves and errors decrease. If you knew there was a system that could reduce errors by 99% and improve productivity by up to fourfold, and also improve work satisfaction and improve patient satisfaction, wouldn't you want to learn and apply this system? Athletic-based Interprofessional Rounds, AIR, has incorporated the principles of championship athletic teams to achieve highly efficient and effective bedside rounds. The same principles are used in lean manufacturing and explain the high quality of today's automobiles. Of course, patients aren't cars, and patient care isn't a game, but this approach has proven to be highly effective in healthcare, as will be described later in this video. There are 3 basic principles that all championships teams apply. 1. Playbooks. Everyone knows their exact roles, eliminating ambiguity of roles and duplication of work. Using football analogies, symphony orchestra analogies can also be applied. The patient is the team owner. The attending is the coach. The senior resident, the quarterback. The interns, the running backs. The nurses, the offensive line. The third-year students, a redshirt freshman. And the case manager, the assistant coach. The second principle, know who is passing and who is receiving, also called customer-supplier relationships. These need to be carefully defined with specific performance and time expectations. Examples include doctor-patient, doctor-nurse, primary care and consulting services. Third, game films. Looking back and asking what went well and what could be improved. This allows the team to continue to get better and adjust the rounding system to the participants. To be an effective team member, each person must be empowered to contribute their ideas, and everyone must know the fundamentals of communication in order to achieve timely rounds, less than 2 hours. The communication protocol that maximizes content and minimizes time to describe hospital progress is the SOAP, Subjective Objective Assessment Plan, and needs to be consistently used to ensure that patients, nurses, and physicians have a shared understanding of the daily plans. Here is an example of ideal bedside rounds. As you will see, everyone, including the patient, participates. This bedside interaction took approximately 3.5 minutes. Mr. Jones, good morning.
Good morning.
How are you? Do you remember me? I'm Dr. Southwick, and this is Dr. Holland, Dr. Bolanos, and Dr. Gady. And this is the case manager, Michelle Lewis, and the pharmacist, Annie Snyder, and you know your nurse, Vicki. We wanted to present at the bedside and discuss your case. Is that okay?
Sure, that'll be fine.
Great.
All right, so as you know, Mr. Jones is our 59-year-old protein chemist who has chronic obstructive lung disease and who was admitted to the hospital for pneumonia. Subjectively, he has felt better over the last 24 hours. His sputum production has decreased, and now he only has scant white sputum production. Objectively, his temperature is 37.2, pulse is 70, respiratory rate of 16, blood pressure 130/80. On his physical exam today, his lung examination only reveals scattered RALs in the left lower lung field, and his E to A changes have now resolved. His white blood cell count has decreased from 14,000 with 90% PMNs to 9,000 with 70% PMNs. His chest x-ray 2 days ago demonstrated a stable left lower lobe infiltrate, and his sputum gram stain revealed gram-positive lancet-shaped diplococci. However, his culture only grew normal throat flora. His urine antigen, though, was positive for strep pneumonia. So for my assessment, Mr. Jones's pneumococcal pneumonia is steadily improving. And my plan, we can discontinue his IV ceftriaxone and continue him on his oral azithromycin alone. And in terms of disposition, if he continues to improve, I think that he could be discharged to home tomorrow.
Great. Mr. Jones, can I take a quick listen to you here? Let me listen to your heart first. Okay, can you sit forward for me? Take big breaths through your mouth. Okay, say E,
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 E.
Right.
So I agree. Why don't we also give him an incentive spirometer, help increase his breathing capacity. Vicki, do you have any concerns for us today?
No, he's been ambulating in the hall without significant shortness of breath. He's eating all his meals. I think a discharge in the morning would be okay.
Is he going to need home oxygen? I noticed his SATs have been a little bit low.
He does have chronic hypoxia with exertion because of his COPD, so he will need home oxygen.
Okay. I can get that set up at home.
Great. So, Mr. Jones, do you have any questions at this point?
Everything seems okay. The azithromycin, when I take it, makes me a little bit nauseous. Is there anything else I could get?
So we could actually give amoxicillin, which would effectively treat the pneumococcus.
That should work.
Good.
I would recommend amoxicillin 875 milligrams twice a day for 5 more days, and based on his response to the ceftriaxone and his estimated renal function.
So ordering amoxicillin 875 milligrams PO twice per day for 5 days?
His insurance covers that.
Great. So, Mr. Jones, our plan is switch you to oral amoxicillin today and discharge you tomorrow for another 4 days of antibiotics after that. Now, just to be sure you understand our plan, could you repeat back the plan for you?
I'm going to be on amoxicillin for 5 days, and then I'll probably go home tomorrow, and I'll have oxygen at home.
Exactly. Really good to see you today, and keep up the great work on healing. To ensure that all nursing needs are met, we've also developed a bedside checklist, TEMP. To learn more about this mnemonic checklist, go to our website under Communication Protocols. What happens when these principles are faithfully applied? Rounds are consistently less than 2 hours. Length of hospital stay decreases. Readmission rates decrease. Satisfaction on the part of attendings, residents, nurses, students, and patients all improve. Lastly, let's look at what can happen to a team's census when AIR is effectively implemented. Remember, each team received the same number of daily admissions. The census depends on input minus output. If care becomes more efficient and output improves as reflected by a shorter duration of hospitalization, the census goes down. As shown in this graph, prior to initiating AIR, the average census was 18. As AIR was implemented, note the progressive reduction in census, the last day achieving a census of 4, or greater than a 4-fold increase in productivity. Once the system was discontinued, the census quickly climbed back to 18. Each school can and should customize the AIR system. At UF, we call our system Gator Rounds. University of Georgia and Yale University hospitals could use Bulldog Rounds. Any mascot can be used and adds a sense of belonging and teamwork. Please review the game plans, playbooks, and communication fundamentals on our website. With these tools in hand, you too can achieve patient-centered, efficient, and effective care and experience the satisfaction of being part of a winning team.